Welcome to this Prevea orthopedic presentation, all about evaluation and treatment options of common shoulder disorders. Let's welcome today's presenter, Dr. Daniel Metz.
Good morning. Hope everyone's doing well this morning. We're going to be talking about shoulder disorders, and there's going to be a full assortment of shoulder things. And one of the things that's tough to do is give a talk on PowerPoint versus face-to-face, because face-to-face I can usually be pretty dramatic. I can use my hands. I can show you a few things I'm doing. So I tried to get a lot of slides and pictures to help kind of show things so you could understand those as good as possible. So let's get started here. So Prevea, we have lots of different sites. We kind of have an Eastern and Western division, and there's little spots on both sides. So depending on what side of the state, if you want to see somebody in orthopedics, we're usually located in some of the bigger cities as listed above. So an overview of shoulders. We're going to start with some anatomy. Then I'm going to show you some pictures and describe some how ways we examine your shoulder. Go through a few x-rays as well to explain what we're looking for on an x-ray. And if you look to the picture to the right here, this is actually an x-ray of someone's shoulder right here. This is your big arm bone called your humerus. This is your collarbone. And the third bone that we look at is called your scapula. And then we're going to be talking about the different types of injuries. And some injuries are traumatic. We have AC joint injuries and fractures. And some are just wear and tear, impingement, rotator cuffs, biceps, instability, arthritis, and frozen shoulders. So we're going to go through those one at a time here. Well, let's start with basic anatomy. So when you look at someone's shoulder here, and if this is someone's neck over in here, the shoulder consists of, this is your sternum, this is your scapula or shoulder blade, this is your collarbone, and this is your arm bone called your humerus. So there's four different things that articulate. The most common area of articulation is just called a glenohumeral joint. And this was what lets you raise your arm above your head, reach behind your back, rotate it off to the side. Your collarbone joint right in here, it has a little bit of movement, but it's a pretty tight joint. Once again here, there's a third joint here between your collarbone and your sternum, and it's very rare to have an injury there. And the last one, and people don't always think about, is called your scapulothoracic. This is where your shoulder blade rotates on your rib cage. So sometimes people can feel some popping and snapping on the back, and usually it's a little bit of a muscle imbalance on the back of the shoulder. Now, in terms of the soft tissue around your shoulder here, so if you looked at someone's x-ray, the previous x-ray we could show the bones that are depicted in this light yellow. The things we don't see on x-ray are things like your biceps muscle here that has a tendon that goes through the little groove that attaches on the ball and socket. We don't see the rotator cuff. The rotator cuff has two different functions. Three of the tendons attach on the bone up on top here and form part of the rotator cuff. The fourth tendon attaches on the front portion. It happens, but it's pretty rare to hurt this portion of the rotator cuff. This kind of shows the bursitis that people get above the rotator cuff and below the bones above it right there as well. So there's soft tissue that we can't see on x-rays, and usually an MRI or an ultrasound will help show some of that information. So it all starts with when you sit down with your provider and just trying to ask some basic questions here. So if your shoulder's been hurting, is it truly your shoulder? Could it be your neck? Could it be a nerve in your arm that's being compressed? So there's other things that can cause shoulder pain here as well. But number one here is looking, how long has your shoulder been hurting? Has it been for a week? Has it been a month? I mean, did you hurt it falling out of your deer stand? Did you hurt it and just, lifting up something, some groceries out of the back of the car? So the amount of trauma that involves, the injury, did your shoulder pop out of place? Were you playing football? I mean, it all involves is how much energy went through your shoulder. One of the biggest things I ask people about nighttime sleep is if they have a rotator cuff tear, it's really hard to sleep at nighttime. People find that every time they roll on the injured shoulder, that tends to wake them up. Diabetes. There's a lot of people with diabetics, and if your diabetes is not well controlled, you sometimes get a condition called a frozen shoulder. It happens for no good reason. It usually happens when your diabetes is not well controlled. And then by the time that I see most patients, since I'm an orthopedic surgeon, people have tried ibuprofen, Aleve, Tylenol. those type of things, because we want to know if anything is helping their shoulder pain. So when we talk about a physical evaluation, we talk about looking at the range of motion. So the first range of motion is just how much can you move your arm on your own? That's called active motion. And how much can I move it for you? Because sometimes people try to lift their arm up like this here and they can only get so high, but then I can take their arm and push it up a little bit higher. So there's a difference between passive motion and active motion. Or then we're also going to talk about how much rotation. A good way to describe that would be is if you had to reach up your back and scratch the middle of your back, can you do that or not? Some people can, some people cannot. The flexion extension is just literally lifting your arm up in front of you like this here. And the abduction and adduction is bringing your arm across your chest wall. We checked muscle strengthening on a 0 to 5 score. 5 being perfectly healthy, 0 is you can't move your arm at all. Most people have muscle testing in 3, 4, or 5 range. 3 meaning that they can barely lift it up against gravity. 4 when it's a little weak, and 5 where it's fairly normal. Then we also then look at nerves as well. Sometimes people have compression of nerves, being carpal tunnel or their cubital tunnel. We also check range of motion of someone's neck, because a nerve pinch in the neck can appear to be shoulder pain as well. And then there's lots of special tests that I'm going to get to here in a moment. So when it comes to special tests, so we sat down, I've talked to you for a few minutes, you've kind of told me where you hurt, we know how long it's been going on. One of the first tests here is, if I'm the doctor standing behind the patient here, I'm lifting their arm up over their head. This is called a Near's impingement sign. That test, and you can actually just do it on your own, if you're lifting your arm over your head and you're having pain with that, that could very well be rotator cuff pain or pain around the bursitis of the shoulder. This is another good test to check, is if you brought their arm up into a chicken wing and you try to rotate their arm back and forth, if that hurts, that's another sign of bursitis and or rotator cuff pathology. There's a few tests we look at just checking for strength. And one of those is if you just bring your arm up and I try to push it down if there's no strength. Also, if you're kind of in a chicken wing with your arm straight, if there's just no strength, these tests look for specific muscles of the rotator cuff to find out if there's a weakness specifically in 1 or 2 muscles. In this picture right here is the patient sitting down, and we're trying to take their arm and try to pull it across their chest. And right where this patient, the provider's thumb is, that's where the collarbone sits. So having collarbone pain, if you try to take their arm and pull it across the chest, it's called a crossbody adduction test. We're looking for collarbone arthritis and pain related to that. So as I'm going here, feel free to do some of these tests on your own and just see if they seem to hurt a little bit. And maybe you can self-diagnose yourself with whatever injury that you have. Now, especially for younger patients, if you have something called instability, you feel like your shoulder is going to pop out of place. And this is very common in young people, high schoolers, swimmers especially. Swimmers tend to be a little bit more loosey-goosey, where they feel like they can hyperextend their elbows, and the shoulders tend to either try to pop out of place or actually do dislocate. So the test we're looking here, and this is one you cannot do by yourself, is the patient's laying on their back, and we're actually trying to twist their arm, taking their hand and trying to actually rotate it backwards a little bit to see if I get their shoulder to feel like it pops out of place. This next picture is the provider grabbing the arm bone right there, and we're trying to push it forward and backwards, or maybe even try to pull down to see if it actually looks like the shoulder is loosey-goosey. So the looser you are, well, the higher chances that you'll tend to sublux or dislocate your shoulder, typically. And if that tends to happen, is we'll try to use some rehab typically to try to strengthen the muscles around the shoulder to prevent that from happening. Now the biceps is very common here. So the picture on the left here actually showing the biceps, and it comes up through a groove right here, and then the groove and then attaches on the top of something called your labrum on top here. So to have pain anywhere in this area, this is a good little test right there where the person just lifts their arm up and someone tries to push down on the arm. That's called a Speeds test. So in terms of x-rays, so typically I like to get 4 x-rays of someone's shoulder. There's 2 from the front, there's 1 from the side, and then 1 from the back side. And at some point here is I'll have x-rays of pretty much all of these to look at. And I'll point out the small details. So if you look at the next slide here is looking at age. So a good rule of thumb is most 30-year-old and younger don't come in with wear and tear. They're coming in because they had a collision, they fell out of their tree stand, someone ran into them in a car accident. So they're usually traumatic injuries or instability. To actually have rotator cuff pathology is pretty rare under the age of 30. Then as we get a little bit older, typically that 40, 50, 60-year-old age group, those are people that start getting bursitis of the shoulder. They can get some either full or partial thickness rotator cuff tears. But shoulder dislocations are pretty rare for the first time unless they actually had significant trauma. The problem with dislocating your shoulder once you're over the age of 40 is there's about a 50-50 chance that you may also tear your rotator cuff. So usually rotator cuffs can be injured at the same time of a shoulder dislocation if you're older. If you're younger, it usually never happens. Now, if you look at the last one here, older than age of 60, there's about 20% of Americans that actually have rotator cuff tears. And we're not talking partial tears, we're talking full thickness tears over the age of 70. So if you think about 330 million Americans, there's a lot of people over age of 70. There's probably 60 million people, and about 20 to 25% of those have a rotator cuff tear. The good news is most of those people are asymptomatic. And the people that are symptomatic will usually get better with cortisone shots and or therapy. So let's talk about trauma here. So your AC joint. So you're a football player, you put your head down, try to tackle somebody. That can damage the collarbone joint. The collarbone is the bone right here, and it forms a joint with the acromion. So there's 6 different levels of injury. Typically, the level 1s and 2s are relatively minor. 5s and 6s are severe. 3s or 4s are kind of in the middle. So most people that injure their collarbone, it does not usually require a surgery. So usually the treatment is you put them in a sling, just let them the swelling settle down, start doing their day-to-day activities, and depending on how symptomatic they are and what they're doing for activities, if they're a football player, if they're a volleyball player, maybe a little bit longer off of work or athletics. So depending on the degree of injury will dictate how fast they're going to get back to activities. So most people are back doing day-to-day work in probably a week or two, and probably to 5 to 6 weeks before I let them go back to contact activities. Collarbone fractures. So here's a good example of the picture on the right here is someone's collarbone is snapped in half. So when you break your collarbone, that is usually from some type of a trauma, be it a car accident, falling out of your tree stand, tripping on your dog leash in the backyard, landing on your shoulder. The good news is most of these are non-operative. The downside to collarbones is there's not a lot of muscle around them, so they don't always heal perfectly. And if you're a smoker or if you're a diabetic, they tend to heal rather poorly. So the key here are the 2 pieces of bone. When I say the 2 pieces of bone, they never heal perfect like this here. But if they kind of heal to the point that they're almost touching, then what can happen is there's some bone that forms around it. The key is getting these to heal. And if the bone is still separated like this here, sometimes we recommend doing a surgery to actually put the bone back together and then do plates and screws as well. So depending on how severely it gets injured, it will dictate the treatment. Then the key is trying to get this bone to heal. It usually takes about 10 or 12 weeks for this bone to actually start healing. So then dictated on that is how fast we can get the shoulder moving as well. Probably the most common thing that I see in practice, and I've been around for 20 years, is it's called impingement. Impingement is a good example of where there may or may not be rotator cuff damage, but there's inflammation around the rotator cuff. And that patient usually says, well, my shoulder's been hurting for a couple of weeks. I tried ibuprofen relief. It's hard to sleep on my shoulder at nighttime. Trying to get my arm over my head or reach it behind my back is usually painful for me. It usually doesn't happen with an injury. It just happens kind of over the course of time. And it's a result of inflammation in the bursitis and around the rotator cuff. So if you look closely, this is a picture of someone's surgery here. This is a little metal probe. If you look at the tendon right in here, this is healthy appearing tendon. You can see here is this portion of the tendon is scraped away. But there's not a hole in the rotator cuff, but there's an injury to it where it's partially torn. So sometimes these will get better with shots, pills, and therapy. And sometimes people still have irritation where we need to go in there and clean up the shoulder. So in terms of the physical exam, if you looked at the back of the slides, the first two slides I gave you were a slide on near and also Hawkins maneuver. So those are usually positive. And usually that responds well to doing a cortisone shot and doing some therapy. When I look at someone's x-rays, I'm looking for bone spurs. Sometimes where the rotator cuff attached, there may be cysts or just an increased whiteness of the bone. And sometimes I can see there's a narrowing of the subacromial space. So here's a picture of someone's shoulder here. And this is the bone called your acromion right there. So if you look closely here, I'm trying to get it, that bone is kind of shaped like this here. So if that bone would be flat, there's no bone spur. If that bone has a big hook to it, there's a bone spur. And so every time the rotator cuff right in here slides up and down, it creates damage to the rotator cuff. So the bigger the spur someone has will tend to dictate how much injury you may or may not have to the rotator cuff. So the rotator cuff right here is actually showing a hole. So that would be a full thickness rotator cuff injury. This is someone's MRI picture. So we're looking here, this is the ball and socket of the shoulder right here. We're looking on the MRI here is the tissue right there is the rotator cuff. And you can see how it's nice and thick right through here. Thick, 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 and all of a sudden it thins out. It's actually torn off the edge of the bone right there. So this person has a rotator cuff injury. So a typical way to treat this is anti-inflammatory pills. And usually by the time most people see me in the office, they've tried ibuprofen relief. I like using drugs called diclofenac, meloxicam. Those are a little bit stronger. Those are just once or twice a day versus, every 4 to 6 hours. In terms of activities, if you said, I've been playing tennis, I play tennis for hours on end, it tends to bother my shoulder. Then we talk about reducing overhead activities, swinging, twisting, turning. We order some physical therapy, working on stretching and also strengthening of the rotator cuff. And usually a cortisone shot will really help people immensely. Now, a cortisone shot, and everybody has their own little different concoction of what they like to use. What I typically do is put numbing medication in with the cortisone. So if you leave my office, as you'll get out your car for about an hour or two later, you'll say, wow, that feels really, really good. You can move your shoulder pretty well. Well, that'll wear off. It'll take about a week or so for the cortisone portion to kick in. Now let's talk about when you have bursitis or a partial rotator cuff tear and it progresses, meaning that the rotator cuff now has a full tear to it. And this is someone, I can look in the shoulder here. This is rotator cuff. There's a hole in it. So when there's a full thickness tear, those will tend not to heal up on their own. They will tend to progress over time, meaning that the tear will tend to probably get a little bigger over the course of years. Amazingly, though, is if you looked at every 7-year-old person and older in the United States, 20% of those have rotator cuff tears, and very few of those people complain about shoulder pain. So just because you have a rotator cuff tear doesn't mean we jump and fix it right off the bat. So the different signs of rotator cuff is usually pain over several months. Sometimes you may have remembered hurting it. You reached up in a cabinet and felt a tweak. Some people will say, well, I fell, or I was coming down the steps and I grabbed onto the railing. I may didn't fall to the ground. But usually rotator cuff tears will just happen over the course of time. The biggest thing that I hear of just the stories is pain at night, pain sleeping on their shoulder side. They may say there's weakening, catching, kind of a grinding sensation in their shoulder as well. This is another picture of showing there's a hole in the rotator cuff right here. So physical exam. When I see patients for the first time, I like to get men with their shirts off to be able to look at their skin. And also women, I like to get into a gown to be able to look at their skin. And I'm looking at a couple of different things. Number one, I'm looking to see if there's any scars in your shoulder from surgery before. I'm looking to see if you have skin cancer. A lot of people have skin abnormalities and they don't look on their backs and their shoulders very well. It'd be amazing the number of times I point out a lesion to somebody on their skin and have them see a dermatologist. But then we're also looking to see if the muscles are as big as they should. Over the course of time, if you have a rotator cuff tear, the muscle will shrink down typically. What we're then going to do is check the motion. We're going to check what you can do and what I can do to push you without torturing you too much. Some patients, literally, I cannot examine them very well because their shoulder really, really hurts. And if they hurt that much, that bad, either we go right to a cortisone shot or try to do an MRI to find out if there is a rotator cuff injury. Sometimes you hear some grinding and catching. Now, a good rule of thumb is cracking, popping, or snapping doesn't always mean a bad thing is going on because we can do that with lots of our joints. Usually when you have pain, swelling, or if I can see the muscle is shrunken down, those are usually signs that things are going poorly. So looking at x-rays and MRIs, typically an x-ray will not show a rotator cuff tear. However, the shoulder has a ball and socket to it. When you have a rotator cuff tear up in here and it's a big one, what can happen is the ball can push up to the ceiling. And I can tell that there is a less of a gap between the bones. So sometimes people can have a massive rotator cuff tear and I can see it on the x-ray. But the imaging study of choice for me is an MRI. Now, MRIs are not cheap. I typically do MRIs with an injection of dye into the shoulder. So there is usually one needle stick. The dye helps me get better information about the size of the rotator cuff, if it's a partial tear versus a complete tear, and also to see if there's a labral injury or biceps injury as well. The other problem with MRIs is the cost. If you ever had an MRI and you got your bill, you're probably looking at $3,500 to $4,000 between the MRI and the radiologist reading the MRI. So different treatments. So starting with anti-inflammatory pills, and that may be ibuprofen or leaf. I think those help better than Tylenol. Tylenol is a mild pain medication. It does not bring inflammation down. But unfortunately, some people cannot take anti-inflammatory pills. If you have a lot of heart disease, you shouldn't be taking handfuls of anti-inflammatory pills. Some people have stomach ulcers. You should not be taking anti-inflammatory pills because it can induce a stomach ulcer. So you got to be careful under certain medical conditions. If your kidneys and your liver are not working well, sometimes Tylenol or anti-inflammatories can affect that as well. And then usually do a cortisone shot and adding some physical therapy. Unfortunately, physical therapy is not cheap either. Every time you go to a physical therapist, it's probably close to $250. And as I always tell people, the goal of therapy is to help get your motion back and help get your strength back. So once a therapist kind of gets you to that point, then the goal then is to be able to do those exercises on your own. Now, some people need rotator cuff surgery. Now, when it comes to shoulder surgery, there's lots of different varieties. Typically, you start with a shoulder scope where we make 2 or 3 little incisions, just look inside the shoulder and start cleaning things up. Then, depending on what we find, there may be bone spurs in and around the shoulder. There may be collarbone arthritis pushing on things as well. So when people get a shoulder scope done and they get things cleaned up with bone spurs or collarbone arthritis, usually within 6 or 8 weeks, they're back doing most things. Unfortunately, is if you have a rotator cuff tear, if you ever go into the shopping mall or go to church and you see people that got a big pillow under their sling, that means they probably had a labrum or a rotator cuff tear. Now that rehab is substantially larger. So if you look at the pictures right here, there's 2 pictures. Number one is the picture of the rotator cuff right there. This is where the bone is supposed to be attached to. You can see there's a gap in there. This one shows blue and white sutures, repairing that back to the bone. So the goal of the rotator cuff surgery is to repair the rotator cuff back to the bone. Unfortunately, is they don't always heal. You can go to anywhere in the country, and if someone guarantees they can get your rotator cuff to heal, they're probably not being honest with you. And I look at rotator cuffs as being 3 different sizes: small, medium, and large. A small tear, maybe like the picture on the right here, there's a couple sutures in it holding it back. There's about a 15% chance that it just does not heal. If you have a medium tear, it's maybe closer to 20 to 25%. And if you have a large tear, it may be a 50-50 proposition that it actually heals at all. Fortunately, most people that even if they don't heal, their pain is much better after surgery. So they usually feel better than they did before surgery. Let's move on to biceps. So there's 2 different biceps injuries you can have. You can actually have a rupture, or you can have tendonitis. And if you looked at your arm here, I'm going to hold my arm up. The biceps attaches at the elbow and attaches at the shoulder. So when people have a biceps injury, I get to ask the patient, where do you feel that injured from? It's because it can be from either spot. It's about a 3-to-1 ratio more from the shoulder than at the elbow area, but it can rupture at the elbow as well. So this picture shows how there's like a lump in the biceps right there. Usually the biceps has a nice kind of a longer appearance. This is actually called a Popeye muscle. So it can be associated with a rotator cuff injury at the same time. Sometimes people feel snap, bulge. Sometimes they're black and blue. Sometimes they're not. Once again here, the best way to look at somebody is to be able to look right at their skin and inspect their bad arm compared to their good arm. So the physical examination is usually a bulging in the biceps area. Sometimes you can actually feel a little gap, black and blueness that goes down the arm. If it's actually torn at the elbow, sometimes I can feel how it's torn off the bone. We usually get x-rays, and the x-rays aren't to see if the bicep or rotator cuff is torn. It's looked in to see is how many bone spurs they have that may be irritating those bones. And then the MRI is the best test to look to see if not only where the biceps, if it's injured, but if it's even repairable, because sometimes if it's pulled back so far, it may not be fixable. So if you do have a biceps lesion, then you got to figure out, do you want to fix it or not? The biceps tendon, there's many people that I see that actually have had ruptured biceps tendons, and they come to my office years later and say, well, that doesn't even bother me. It's their other shoulder that hurts. So you can function at a high level without a biceps tendon, but you're going to lose some strength, about 10% of strength of moving your elbow and kind of twisting and turning. If you kind of imagine twisting and turning like a screwdrivers, people have weakness with that at the shoulder. If you tear your bicep at the elbow, you're going to have more weakness. So people that are carpenters and guys that have a lot of activities, twisting and turning, usually we recommend we're trying to repair those if we can. If you're going to choose non-operative treatment, we're talking physical therapy to try to strengthen the other muscles around your shoulder. Typically, the repair is, any athlete, anybody who does blue collar work that's going to be working for many years. If this is your grandfather who's in their 80s, we're probably going to say we're going to try to rehab it, and they'll probably do well with non-surgical care. Shoulder instability. So this is a picture here of this is the ball right there. This is the socket. If you look closely here, the ball is not even aligned up with the socket. That's how it should be. So this person has a dislocated shoulder. The most common reason why is people trip, fall, twist, turn, and it pops out of place. Usually involves some type of a injury to it. But if somebody is very loosey-goosey, meaning that if they're called multi-directional instability, some people have certain conditions where the joints are very lax. It almost always comes out the front, which is anterior. It rarely comes out the backside. Coming out the backside, the most common reason, if somebody who's had seizures, and you freeze up. Seizure disorder, sometimes it'll be posterior. So this is what you don't want to see is your best friend or son or daughter laying on the floor screaming because their shoulders popped out of place. Occasionally people can pop it back themselves, but usually you need to go to the emergency room where they need to give you medications to put you in la-la land just to relax you to pop it back. Rarely does it need to actually be done in the surgical suite. Sometimes, especially as we get older, is you pop it out, plus there could be a fracture and or a rotator cuff tear. The biggest risk is for younger people. If you pop this out as a teenager, there's a high chance it's going to continue to pop out as you get older. The different x-rays here, this is a view called your axillary view here. This is the ball and socket. This is showing how there's a little piece of bone pulled off. So when the shoulder popped out the front, it popped this direction, it broke off a little chip of bone. So a Hill-Sachs lesion is actually a lesion of when the ball pops out this direction, is sometimes there can be a lesion on the backside of the ball of that. So people over the age of 40, especially as we get to be 50, 60, 70, high chance you have a rotator cuff injury along with the dislocation. Sometimes the posterior dislocations could be missed. So that's why getting multiple x-rays of the shoulder after we pop it back in is key to make sure it's popped back into place. First time dislocators, usually we can just put people in a sling. Some people within a couple of days are ready to come out of the sling and do their day-to-day activities. Other people, it can be taking a couple of weeks because of the amount of trauma. So younger people have a high rate of recurrence. So sometimes we recommend surgery at a much faster rate if you were a teenager in early 20s than you are somebody a little bit older. Typically, as we get older, we tend to get stiffer. Stiffer means they'll have a less tendency to pop out of place. Some people actually can pop their shoulder out of place just by playing with it. It's almost like a little circus trick that they can do. That's actually not good. And if you tried 3 months of rehab and your shoulders continue to pop out of place, it may very well need a surgery. And the surgery would be is to tighten up the shoulder and repair something called your labrum. So shoulder arthritis. So if you're logged on with me today and you're over the age of 50, and you notice that it's having a hard time reaching up your back, or have a hard time changing light bulbs in the house, it could very well be because the ball and socket is wearing out. And then you start getting some bone spurs down in the joint down in here. So when people have arthritis, it doesn't hurt all the time. It usually hurts with activities that are more the extreme. Like I said, reaching over your head, reaching up your back, even trying to put your wallet in your back pants pocket is harder and harder to do. It could be related to an activity. It could be related to actually, falling, twisting. There's a lot of people out there who have shoulder arthritis, and then all of a sudden they have some trauma, and the trauma then aggravates the pre-existing arthritis. The biggest thing we really notice is lack of motion here. So range of motion is dropping. Sometimes you can hear some grinding and cracking. And if you actually put your hand on your shoulder, if there's a lot of grinding, that's usually not a good sign with that. So physical exam here is literally just putting my hand on someone's shoulder and I can hear the grinding, cracking, popping, snapping. The lack of motion is the other thing here. Sometimes you can see the muscles have shrunken down as well. So different tests is if the ball and socket's right up in here, sometimes you can tell is when the rotator cuff, and I say rotator cuff, usually lives in this spot right in here. If the ball and socket keep pushing up to the ceiling, that's usually a sign that the rotator cuff is gone. And that's a condition called rotator cuff arthropathy. But a typically of x-ray findings are bone spurs, some erosions, and flattening of the humeral head. The different treatment options is, like we talked before, is finding activities that work for you. And as I tell people, if you said, hey, changing light bulbs bother me, guess what? You should use your other hand to change your light bulbs. If there's certain activities that you want to be doing, trying to do low demand stuff, like for example, if you were in your garage, working on your tool bench all day long is good. Trying to hang all your equipment on the walls overhead is probably not the best. So you use anti-inflammatory pills. Therapy sometimes is helpful. Sometimes it'll aggravate people because the therapists want to get it moving a lot more. Cortisone shots, not into the rotator cuff, but into the ball and socket is usually very helpful. The picture to the right shows someone with an artificial ball. And so the socket is right there. And actually the ball is held on by a piece of metal. So if you've had a hip replaced, this is typically what we do. The ball is not just replacing the ball, but it's actually putting a piece of metal down your humerus. Shoulder replacements aren't usually as great as hip and knee replacements, but the results are getting better over the course of time. And the last topic we're talking about here is called frozen shoulder. So frozen shoulder, sometimes people will come to my office and I'm starting to talk to them, examining them, and I'm thinking they have a frozen shoulder. And sometimes it'll very well be arthritis instead. So they go hand in hand, where the biggest thing is lack of motion. It's typically in somebody who's a diabetic, and usually a diabetic who's not super well controlled. But even if a diabetic is well controlled, you can still get a frozen shoulder. Sometimes you can actually have other endocrine disease called hypothyroid. Sometimes other medical conditions will create a frozen shoulder as well. There's different phases of frozen shoulders here. And as I tell people, nobody wants to hear this, but if I went and just took you and locked you in your closet at home and had you come out after a year and you did nothing, no pills, no shots, no therapy, a frozen shoulder will typically get better on its own, but it may take a full year. The reason why people are in my office is because they hurt, they can't sleep, they don't have the motion that they would want. So typically you try to get that better by doing some therapy, some shots of cortisone and anti-inflammatory pills. That seems to improve how fast we can get them better. So a physical exam is usually lack of motion, and the lack of motion is usually reaching up the back and or reaching above shoulder height. Sometimes people will hurt, and so rotator cuff pathology, impingement will sometimes be hand in hand with frozen shoulders. Usually x-rays are fairly normal because they should not have arthritis if that's the case. This is a picture of someone's inside their shoulder joint. This is the balls of their shoulder. The red inflammation is, that's how frozen shoulders look. They look very inflamed. So that's why we tend to do cortisone shots into the ball and socket rather than on the rotator cuff for a frozen shoulder. The treatment options is anti-inflammatory pills, physical therapy, cortisone shots, educating people that it's going to take time for this to get better, but it typically would. On rare occasion is they need something called a manipulation under anesthesia, where we take you to surgery and just put you to sleep. And with you asleep, as I break up the scar tissue in your shoulder. That's more common for knees than it is shoulders, but it can be done. And the best thing the patient can do is get their sugars under control. So that is the conclusion of this talk here. So I'm going to turn it over to Chris to see if there's any questions for me.
Thank you very much, Dr. Metz. Again, folks, if you have any questions, please go ahead and put them in the chat function, and I will certainly get those. Dr. Metz, I do have 2 questions so far. Upon a patient coming into your office, is there anything specific that you're looking for as far as an indication that will say, yes, you're likely going to have surgery versus therapy or non-operative functions?
The biggest thing is the amount of energy that went into the problem. If somebody comes in and said they fell hard on the ice and landed right on their shoulder, if the x-rays don't show a fracture, I will typically MRI them right off the bat, because the more energy that goes into the arm will dictate a fracture or a rotator cuff tear. So that'll be the first thing, just someone tell me how they got injured.
Okay, thank you for that. And another question, do significant shoulder injuries lead to higher occurrence of other shoulder or elbow injuries later on down the road?
That's actually an excellent question. We see this very commonly when people have carpal tunnel on one hand. I usually see them years later for carpal tunnel on the other hand. If they have knee arthritis on one side, they're probably going to get knee arthritis on the other side. So I would say there's more than a 50% chance that if they had pathology in one shoulder, they're going to probably get it in the other. And there's going to maybe as simple as bone spurs. It could be a rotator cuff tear. People tend to come back, and they usually know what it is at that point then too. And usually they don't wait as long because they know that, hey, I've already had rotator cuff surgery on one side. My other shoulder feels the same way. it's pretty typical. Especially if you're diabetic and have a frozen shoulder on one side, they know it's the other side going on now, so it's very common.
All right, excellent. And we do have one question from Susan in the chat. How long should a person wait for dealing with their shoulder pain before they make an appointment to see a shoulder specialist?
Good rule of thumb: if they tried some ibuprofen and leave, if they can't sleep at nighttime, it's been going on for 2 or 3 weeks, that's probably a good chance here, because we all have had aches and pains. And if the aches and pains just aren't going away with this simple thing, and you can't sleep at nighttime, that's the time to come in.
All right, thank you very much. With that, there is one other question. It was a little bit specific, so I'm going to try and make it a little bit more vague to avoid the advice portion of it. We have an individual kind of with the shoulder, upper back inflammation, looking at exercises and making meals are being problematic for him. Other than the medications and some of simple exercises, is there anything that this patient should be doing?
Well, I think the big thing you already said is it's shoulder and upper back. And the biggest thing here I'm going to point out, so there's a muscle here called your trapezius, connects your neck to your shoulder. That's a very common area that's sore. And it's kind of like, what came first, the chicken or the egg? Did the shoulder start or did the neck hurt? And it's tough to answer really what to do and what not to do. But, that's why a lot of times I'll see somebody and I'll just say, this is not your shoulder, this is your neck or back. And then we either get the therapist involved and or get a neck specialist involved. So there's lots of overlap between those two problems, and it's hard to answer that question without actually seeing the patient.
Understood. Thank you again, Dr. Metz, for a great presentation. We really appreciate it. And to all of you, thank you so much for attending this presentation. We hope you found it valuable and helpful. Just a reminder that when you receive the survey, we strongly encourage you to fill that out and submit it, as it does help us in future presentations. If you have any additional questions regarding this presentation or anything else orthopedic related, please feel free to give us a call, and we will be happy to assist you in any way we can. Thank you all very much, and we hope that you have a fantastic day.